Think about what happens when you're driving down the highway, right? And suddenly your car's check engine light just flashes on the dashboard.
Yeah, you definitely wouldn't just ignore that.
Exactly. I mean, it's this bright, unavoidable warning signal that something under the hood requires your immediate attention. You wouldn't pretend it wasn't happening, but imagine if society told you that the proper response to that light was to just, put a piece of black tape over it, ignore the grinding gears, and keep driving.
Well, it would inevitably ruin the engine. And that expectation of silent endurance is actually deeply embedded in the cultural narrative surrounding women's health, especially when it comes to experiencing pain during sex.
Right. So, welcome to the deep dive. Today, we are taking on a mission for you, the listener, to unpack a topic that is incredibly common, but surrounded by this really heavy, suffocating silence. We're talking about navigating painful intercourse, which is medically known as dyspareunia, and really looking at its profound impact on a couple's intimacy.
It's such an important topic.
It really is. And to guide us, we've pulled together a massive stack of source material. We have clinical practice guidelines, NHS trust leaflets, the British Menopause Society's consensus statements, and even literature on psychosexual therapy.
And synthesizing all of this really reveals that dyspareunia is, well, it's the ultimate biopsychosocial condition. It is a very complex knot. The medical literature makes it very clear that this is not just a purely physical issue, and it's certainly not, all in your head.
Oh, definitely not.
It's an intricate intersection of physical tissue pathology, the psychological impact of anticipating pain, and the relational dynamics between partners. And untangling that knot clinically, it begins with a vital distinction. You have to differentiate between superficial pain, meaning pain felt right at the entrance of the vagina, and deep pain, which is felt higher up in the pelvis during deeper penetration.
Which makes sense, right? Because that distinction helps isolate the cause. To figure out how to fix the intimacy and the psychological distress, we really have to start under the hood. We have to understand the biological environment that is causing that initial check engine light to go off in the first place.
Absolutely.
And looking through these sources, there is one primary culprit for superficial pain that just comes up repeatedly.
Yeah, we are looking at genitourinary syndrome of menopause, or GSM. And to give you a sense of the sheer scale of this issue, the British Society for Sexual Medicine highlights a staggering statistic. Around 70% of women experience symptoms of GSM, yet only 7% actually receive treatment.
70%. I mean, that is a massive portion of the population. And the sources note that only about a quarter of women even volunteer this information to their doctors, which means the vast majority are literally just suffering in silence.
They are, and a major factor driving that silent suffering is the progressive nature of the condition. Many people, they associate menopause with vasomotor symptoms, like the classic hot flashes.
Right, which are terrible on their own.
They are awful, but for most women, they eventually fade as the body adjusts. GSM is entirely different. It worsens over time due to the chronic starvation of estrogen.
So let's get into the mechanics of that starvation, because I always kind of assumed vaginal dryness was just a temporary lack of lubrication, like a fleeting thing. But reading this, it's an actual structural change, right? The tissue is physically altering.
Completely altering, yeah. Estrogen receptors are packed densely throughout the entire pelvic region. They are in the vagina, the vulva, the urethra, and the pelvic floor. When estrogen levels plummet, those tissues undergo drastic anatomical changes. The medical literature describes how the vaginal walls become thin, dry, and, well, incredibly fragile.
There's a detail here about the physical structure of the vagina that really caught my eye. It naturally has these folds called rugae, almost like the pleats of an accordion.
That's a great way to picture it.
Yeah, and they exist to allow the tissue to expand and stretch comfortably. But with the loss of estrogen, those folds literally disappear. The walls smooth out, they lose their elasticity, and the tissue becomes so friable that the simple friction of intercourse can actually cause it to tear and bleed.
And that tearing, that structural breakdown, it really explains why the medical community's recent name change for this condition is so vital. Up until 2014, the clinical term was vulvovaginal atrophy.
Honestly, thank goodness they changed it. I mean, atrophy sounds like a terrifying medieval curse. It sounds like your body is just turning to dust and blowing away.
It is an incredibly discouraging word for a patient to hear. But more importantly, the old term was clinically just too narrow. It only focused on the vagina. The shift to genitourinary syndrome of menopause captures the full spectrum of what is actually happening.
Because it's not just about sex.
Exactly. Because of that estrogen starvation, it's not just about vaginal pain with sex. It also covers urinary frequency, urgency, and recurrent urinary tract infections.
I really want to pause on the urinary aspect for a second, because if you're listening to this and you've been getting recurrent UTIs in your late 40s or 50s, your doctor might just keep handing you rounds of antibiotics.
Right, which is so common.
But what this deep dive reveals is that the actual root cause might be estrogen starvation in the pelvic floor. The antibiotics are basically just putting tape over your check engine light.
That is a perfect way to look at it, and the anatomy explains why. There is an area at the base of the bladder called the trigone. It is absolutely loaded with estrogen receptors. When estrogen drops, the protective lining of that trigone thins out, just like the vaginal walls.
Oh, wow. So it's the exact same mechanism?
Yes, that thinning makes it infinitely easier for bacteria to grab hold and cause an infection. And because the symptoms are so broad, from painful sex to constantly needing the bathroom, women often just accept them as a normal part of aging.
But the source material is quick to point out that this is not exclusively a menopause issue, right? Like, it can happen anytime the body drops into a low estrogen state.
Yeah, the underlying mechanism remains the same regardless of age. It affects women who are exclusively breastfeeding, women taking certain progestogen-only contraceptives, or, individuals who have undergone chemotherapy or treatments for estrogen receptor-positive breast cancers. The tissues are starved, and they react accordingly.
So we have this biological environment where the tissues are fragile, dry, and easily injured. But the body doesn't just register that local pain and leave it at that. It triggers a systemic muscular defense mechanism that essentially traps the person in a downward spiral.
Right, because your brain's primary evolutionary job is to protect you from harm. Think about a flinching reflex. If someone suddenly throws a ball at your face, you don't consciously decide to blink and duck.
No, you just react.
Exactly. Your nervous system hijacks your muscles and acts to protect you before you even process the thought.
You're just hardwired to defend against a perceived threat.
Precisely. Now, apply that neurological hardwiring to the pelvic floor. If penetrative sex hurts once, maybe because of that tissue fragility or a tiny tear, your brain logs that specific environment as a threat. The next time you attempt intimacy, your brain anticipates the pain. It subconsciously and involuntarily tightens the pelvic floor muscles to build a defensive wall.
Which, ironically, pretty much guarantees the pain will be worse, because now you are trying to force penetration through highly tensed, guarded muscles.
Right.
And that creates more pain, which tells the brain, see, I told you this was dangerous. The fear goes up, the tension goes up, and you end up with a highly sensitized nervous system where even the smallest touch sets off alarms.
And over time, that self-reinforcing loop can lead to a condition called vaginismus, where the involuntary tightening makes penetration practically physically impossible.
I found an analogy in the NHS source material that beautifully illustrates this tension. They say holding tension in the pelvic floor is like gripping a car's steering wheel too tightly while you're driving in a storm.
Oh, I like that.
Yeah, you don't even realize you're doing it. Your knuckles are white, your shoulders are locked up to your ears. You only realize the tension is there when the storm passes, and you deliberately force yourself to relax your arms. You realize you still have total control of the car, but you aren't exhausting your muscles in the process.
That's a great visualization. And breaking the pain cycle requires an active, conscious unlearning of that death grip on the steering wheel. You have to prove to your brain that the area is safe. And this is really the domain of specialist pelvic physiotherapy.
And we should clarify that this isn't just about doing more Kegels, right? Like, that's not what this is.
No, not at all. Actually, doing standard Kegel exercises, which are designed to tighten and strengthen the muscles, can actively make dyspareunia drastically worse if your pelvic floor is already hypertonic, meaning, it's overactive and unable to relax.
Well, that makes total sense.
Yeah, pelvic physiotherapy for pain focuses on the exact opposite. It is called down training. The goal is elongation and relaxation.
But how do you actually downtrain a muscle you can't even see? I mean, it's completely internal.
It starts with the nervous system. Physiotherapists use diaphragmatic breathing. By breathing deeply into the stomach so it expands, the diaphragm drops down, which naturally forces the pelvic floor to drop and stretch. They also use targeted manual techniques, like teal massage.
What exactly is teal massage?
Well, the pelvic floor isn't just one muscle, it's a complex hammock of muscles, including the levator ani group. Teal massage involves the therapist applying gentle, sustained internal pressure to specific trigger points in that muscle sling. It's very similar to finding a hard, painful knot in your shoulder blade and pressing on it until the muscle fibers finally give up and melt.
Okay, so you're teaching the muscles to release the tension. You're teaching your brain to let go of the steering wheel. But how do you actually practice that? You can't just jump straight back into penetrative sex if your brain is still terrified of the pain. How do you bridge that gap?
This is where vaginal dilators become a vital tool. They are smooth, graduated cylinders, often made of medical-grade silicone. You start with the absolute smallest size, sometimes no bigger than a pinky finger. It essentially operates on the psychological principle of graded exposure therapy.
So you are systematically desensitizing the alarm system.
Yes. By inserting the dilator in a safe, controlled environment where the patient is in total control of the speed and depth, they slowly stretch the tissues and provide new data to the brain. The brain learns that penetration does not automatically equal pain.
But that doesn't happen overnight, right?
No. Resetting those pain receptors takes consistent, deliberate effort. The guidelines generally indicate it requires 8 to 12 weeks of dedicated physical therapy to create true, lasting muscle change.
Wow, okay. But if my tissues are literally starving for estrogen and structurally breaking down, physical therapy alone isn't going to rebuild those accordion pleats we talked about. What do we actually do about the biological environment? Just slather on some moisturizer.
Let's break down the medical toolkit, starting with the conservative, non-hormonal options. It is crucial to distinguish between lubricants and moisturizers, as they serve entirely different functions. Lubricants are strictly for short-term friction relief. You use them right at the moment of sexual activity.
And the sources mention looking out for the ingredients on those. You want to avoid flavors, warming gels, or parabens because those additives can irritate tissue that is already compromised.
Absolutely.
Also, if you rely on latex condoms, oil-based lubricants are completely off the table because they degrade the latex and cause it to break.
Good point. Moisturizers, conversely, are absorbed into the tissue. Think of them like a daily face lotion. You apply them regularly, maybe 2 to 3 times a week, to maintain tissue hydration and help balance the vaginal pH, regardless of whether you're planning to have sex.
Those sound like good baseline habits, but the clinical guidelines elevate one specific treatment far above the rest. They call it the gold standard for GSM.
Yes, local vaginal estrogen is the definitive gold standard. It is delivered directly to the vulvar and vaginal tissues via cream, a tiny dissolving tablet, or even a flexible silicone ring.
I imagine a lot of listeners hear the word estrogen and immediately worry about the systemic risks, right? Like blood clots or breast cancer, things that are sometimes associated with hormone replacement therapy.
That is a very common and completely understandable fear.
Yeah.
But the mechanics of local estrogen are entirely different. Because it is applied directly to the starved tissue in very low microdoses, the systemic absorption into the bloodstream is negligible.
So it just stays locally where you put it.
Exactly. It stays exactly where it is needed. That makes it incredibly safe for the vast majority of women and highly effective at restoring tissue thickness, returning the elasticity, and rebuilding those natural folds.
Now, the clinical guidelines also outline a few alternative pharmaceutical options if estrogen isn't suitable. There's a vaginal DHEA insert, known as prasterone, and what I found really fascinating about DHEA is its mechanism. Once it's inserted, the body's own cells convert it locally into both estrogen and testosterone. Why does the testosterone matter there?
It's super interesting. Testosterone plays a critical role in vaginal health that is often overlooked. It helps maintain the density of the nerve endings, which is vital for sensation and arousal, and it also contributes to the function of the glands that produce natural lubrication.
The sources also list an oral medication called ospemifene, which honestly confused me a bit. How does a pill know to target the vaginal tissue without causing estrogen-related issues everywhere else in the body?
Right, it seems like magic, but ospemifene is part of a class of drugs called selective estrogen receptor modulators, or SERMs. It is a brilliant bit of pharmacology. It acts like an estrogen agonist in the vaginal tissue, meaning it turns on the estrogen receptors there to rebuild the tissue, but it acts as an antagonist in other parts of the body, like the breast.
Meaning it blocks estrogen activity there.
Exactly.
That is a really neat biological trick. Now, alongside adding these treatments, the clinical guidelines stress the importance of a thorough medication review. The sources point out that some incredibly common prescriptions can actively cause or worsen dyspareunia.
Oh, absolutely. SSRI antidepressants are a classic example. While vital for mental health, they can act as chemical sensation blockers in the pelvic region, delaying orgasm and severely dampening libido. Another major hidden culprit can be certain hormonal contraceptives.
Yeah, let's break down how a contraceptive pill actually causes dryness. The literature mentions something called sex hormone binding globulin, or SHBG.
Right, so certain oral contraceptives cause the liver to ramp up the production of SHBG. Think of SHBG like a massive fleet of biological taxicabs circulating in your bloodstream. Their whole job is to pick up free-floating hormones, particularly testosterone.
Okay, so if the pill puts 1,000 extra taxicabs into your bloodstream, they just pick up all the free testosterone. It gets trapped in the cabs, meaning it can't reach the vaginal tissues that desperately need it for lubrication and healthy nerve function.
That is exactly the mechanism. And sometimes simply working with a doctor to switch to a different contraceptive or antidepressant can dramatically improve the symptoms without needing any complex interventions.
I have to bring up a trend that contradicts a lot of this clinical advice, though. I look at the modern wellness industry and I see aggressive advertisements for treatments that sound much more high-tech. If local estrogen and pelvic physiotherapy are the proven gold standards, why are clinics pushing vaginal lasers, radiofrequency devices, platelet-rich plasma O shots, and even hyaluronic acid fillers?
Navigating the commercial wellness space versus evidence-based clinical medicine is notoriously difficult for patients. According to NICE, the National Institute for Health and Care Excellence, these procedural and energy-based devices are strictly categorized as second-line adjuncts.
Meaning they should never be the starting point.
Correct. They should generally only be considered for patients who have completely failed conservative therapy or who have strict medical contraindications to any form of estrogen. Even then, Nisajim advises that laser treatments for urogenital atrophy should largely be confined to a research context. We simply lack robust, long-term safety and efficacy data.
Okay, what about the injectables, like the O shots?
Well, platelet-rich plasma might stimulate some localized tissue regeneration, and hyaluronic acid fillers can physically plump the tissue to provide a structural cushion. But they're very expensive, the results are completely temporary, and they lack the rigorous clinical trials that back up topical estrogen. They really must be approached with a heavy dose of informed consent.
That is a crucial distinction to make. But let's imagine a scenario where a listener follows the evidence. They go to their doctor, they start the local estrogen, they diligently attend pelvic floor physiotherapy. The tissues heal, the muscles learn to relax, the physical machinery is entirely repaired. And this is but fixing the biology is only half the battle, isn't it? If a relationship has been strained by months or even years of painful sex, how do you repair the emotional connection?
That is the big question. We have to transition from the biological to the psychological. Because painful sex creates an immense emotional crater in a relationship. The partner experiencing the pain often carries a heavy burden of guilt, feelings of inadequacy, and severe performance anxiety.
It's devastating.
And the other partner often grapples with intense frustration, confusion, and a profound, paralyzing fear of causing the person they love physical harm.
The psychological sources outline how this dynamic inevitably leads to total sexual avoidance. Like, you just stop going into the kitchen entirely because you know the stove is hot. Couples stop holding hands, they stop cuddling on the couch, because there is this unspoken terror that any physical affection will be interpreted as an invitation to penetrative sex, which both partners know will end in pain.
Exactly. The physical intimacy just evaporates. Rebuilding it requires specialized tools. Psychosexual therapy heavily utilizes a framework developed by Masters and Johnson called sensate focus.
I've read a bit about that.
Yeah, it is a highly structured, non-demand touching exercise. And it begins with what seems like a really radical first step. It requires a total clinical ban on penetrative intercourse.
A prescribed sex ban? I mean, I can see how that immediately deflates the tension. It just removes the elephant in the room.
It completely takes all the performance pressure and throws it out the window. With the goal of intercourse officially off the table, the couple is tasked with taking turns touching each other in a mindful, entirely non-judgmental way. The goal is not arousal. The goal is not orgasm. The goal is simply sensory awareness.
This connects to a concept from the literature that perfectly captures the mental block of dyspareunia. They talk about the battle between the evaluative brain and the experiencing brain. Like, if you go to a beautiful Michelin star restaurant, but your job is to write a harsh, critical review for a newspaper, you aren't actually enjoying the meal. You are just analyzing the salt content, checking the temperature, monitoring the waiter's speed. You are entirely in your evaluative brain.
And when you have a history of painful sex, Your brain operates exactly like that restaurant critic.
Mm.
You are constantly monitoring. Is this going to hurt? Am I taking too long? Is my partner getting bored?
So sensate focus is essentially firing the food critic so you can just, enjoy the taste of the meal again.
That is exactly what it is. It
Mm.
forces the brain out of the future, where it is anticipating the pain, and anchors it in the present moment. In the first stage of sensate focus, partners take turns touching only non-genital areas of the body. The instruction is to just gather sensory data. Is the skin warm or cool? Is the texture rough or smooth? What is the pressure of the touch like?
You aren't judging it as good or bad, you are just noticing it.
Right. If the person being touched feels any discomfort, they communicate it. But otherwise, they just receive the touch. Over several weeks, as physical trust is rebuilt and the nervous system learns that touch is safe again, the exercises progress to include genital touch. But crucially, it remains without the expectation of intercourse.
It's about retraining the brain.
By deliberately taking the pressure off, the couple can slowly relearn each other's bodies. They literally rewire the brain's association with physical touch, leaving the baggage of past pain behind.
It really acknowledges that you can't just slap a bit of estrogen cream on a check engine light and expect a couple who hasn't been intimately connected in 3 years to suddenly have a flawless sex life. The emotional wounds require just as much deliberate rehabilitation as the vaginal tissues do.
They absolutely do. It takes immense patience, open communication, and a willingness to engage in guided exploration.
Well, let's wrap all of this up for you, the listener. If there is one core truth to take away from this deep dive, it is that painful sex is not an inevitable life sentence. You do not have to put black tape over the dashboard. By addressing the physical tissues, whether through regular moisturizers or the proven gold standard of local estrogen, and by retraining the pelvic floor muscles to finally let go of the steering wheel, and by resetting your psychological expectations through therapies like sensate focus, true intimacy can absolutely be restored.
And as we close, the breadth of this source material leaves us with a pretty profound final thought to ponder. We spend an enormous amount of clinical effort, time, and physical therapy trying to restore a patient's ability to have penetrative intercourse.
We really do.
But what if society's rigid, goal-oriented definition of real sex, viewing it solely as penetration, is actually our biggest obstacle? If we actively expanded our cultural view of sexual pleasure to prioritize outer course, mutual exploration, and sensory connection as equally valid and fulfilling, how much of the anxiety, guilt, and relational trauma surrounding dyspareunia might simply vanish?
It is an incredible question. Maybe it's time we stop staring at the check engine light, terrified that the car is broken, and realize there are entirely different, beautiful roads we can drive down together. Thanks for joining us on this deep dive.